We are going to be talking about child abuse. As a pediatric surgery trainee, this is a topic which is very close to my heart, and I've seen numerous cases of child abuse. It can be non-accidental injury, physical abuse, it can be sexual in nature, and it's very horrific and traumatic for the child. It could be from the parent, it could be from the grandparent, it could be from the neighborhood friendly uncle or auntie who's very nice to everybody in the family but turns out to be a monster. All of us have seen people like that. The society is very afraid to talk about it. You don't be that person. You don't be an abuser and never enable abuse. A child's life can be traumatized completely just because you wanted to adhere to certain social norms. Never be that. How do you diagnose child abuse and non accidental injury? The history is usually evasive, changing. The father might say something, the mother might say something. Presentation is usually delayed. The child might have been hurt a few days ago. They might have bought him only after 2 to 3 days. The mechanism of injury is implausible. The child has injuries in the back. Mother says the child fell from the ground or from the bed on a face down position. Inconsistency of the age of the injury or the burns. History of the child being left with a supervisor or a carer who appears to be suspicious. Lack of guilt. They might try to act guilty, but they usually end up failing. These abusers are usually psychopaths, and they really don't have any sort of care for the child. Lack of concern about treatment or prognosis is also seen. Signs of child abuse. Long bone fracture in a child who is not yet walking. A child's bones are very flexible, are very soft. They don't easily fracture, especially if the child has not started walking. A single fracture with multiple bruises, definitely possible. Multiple fractures in various stages of healing suggest chronic abuse. Corner fractures. What is a corner fracture? Or transphysial separation of the distal humerus. Basically, Salter-Harris fractures, metaphyseal injuries, where the child's arm is twisted by the abuser, by the carer. This is a very common injury and is very, very diagnostic of child abuse. At this point, I must, of course, emphasize that you should rule out metabolic abnormalities, bony abnormalities, before blaming the parent or the carer. But yes, these should induce suspicion. Posterior rib fractures. You hold a child, shake it, the battered baby. Your 4 fingers of both the hands compress on the posterior ribs. Remember, anterior rib fractures are not seen in non-accidental injury. It's usually posterior rib fractures. New periosteal bone formation, indicative of fracture and injury, healing. Skull fractures, intracranial injuries, shaking the baby. And again, as you mentioned, transphysial separation of the distal humerus. Bad burns. Cigarette butts, very common. Usually the abuser is a male, the partner of the mother, who doesn't care about the child. So you will see rounded ulcers or erosions with singed hairs, vellus hairs. Branding, very common in certain South Asian cultures. You will see that they've taken the fork or the spoon and branded the child. You will see the mark on the skin. Be very suspicious. Emotion injuries. Scalds are very common in children. Scalds are literally the most common type of burns in children. But when a child falls accidentally, he goes head first. They're just trying to dip in there. So you will see burns on the face and the head. You will see burns on the hands. But in non-accidental injury, the child is dug into the water. And that can result in a very characteristic donut-type sparing or a glove and stocking distribution with a uniform depth of burn. The child is immersed. You will see that there are zebra stripes where the child has been held, and those are areas where you might not see burns. At the spot where the buttocks touches the bottom of the bucket or the container, the child is usually in a forced submersion reflex position. You will see that there is sparing around the buttocks. This is very classical of a non-accidental injury where the child is dunked into scalding water. Very suspicious, very cruel to hear and see all these injuries. But this is the reality, and you should be in a position to pick up. If your knowledge is inadequate, you might be enabling abuse. Here we have an image of a child being burned by cigarette butts. Very tragic. An 18-month-old boy, Piyush Nagpal, is admitted to the pediatric unit with injuries sustained while in the care of his mother's partner. You're concerned that a non-accidental injury might have taken place. Which of this is indicative of child abuse? Bruising over shins, all children get bruised over shins. Injury consistent with history, no. Injury inconsistent with history is more indicative of non-accidental injury. Metaclavicular fractures and supracondylar fractures common in children. Supracondylar fractures falling on an outstretched hand, very common. Rib fractures, as we mentioned before. But again, make a note, it's posterior rib fractures, not anterior rib fractures. Nyla was bought with scalp injuries. She's 6 years old. So which of this is suspicious? Child was brought immediately to the hospital. No, that's not suspicious. That's a good thing. That means that the mother is concerned. Clear history of incident, again, not indicative. The burn looks infected and is oozing. Very suspicious, because an infected wound means that the child did not go into the tub half an hour ago, as we can see in the history. Child was brought in with few days delay. The mother looks and feels very guilty about the incident. Option D. Option E, both C and D. When we put up this question on our Mortimer Green WhatsApp group, most people chose option E. That is the wrong answer. The answer is option C. Most parents tend to feel guilty, whatever be the nature of injury or whatever be the nature of burn. You take your child out for a walk in chilly weather and the child catches a cold, you are going to feel guilty. So parents, good concerned parents, tend to feel guilty about any illness or any injury the child has suffered. They tend to think, oh, what could I have done better? Oh, why didn't I do this? Why didn't I lock the door? Why did I leave the heater on? So those are thoughts which occur in a child, and that is natural for every parent. The answer is C. The burn looks infected and is oozing. One more question. 9-month-old child, inconsistent history. What is suspicious? Anterior fractures? No, it is posterior. Clubfoot deformity. Children are born with clubfoot deformity. Femoral shaft fracture. The child is 9 months old, not walking. Yes, this is the answer. Hip dislocation. Congenital hip dislocation of hip is very common. Bruising over both knees. The child crawls. It's 9-month-old. Would have crawled on a rough surface. Bruising is very common in children. In fact, when we were children, both my brother and I, our father would tell that if you guys don't have both your knees bruised, that means you guys are not playing enough. So the answer here is femoral shaft fracture. That is a long bone fracture in a child who is not walking. Thank you so much for listening to us patiently. We have a very comprehensive set of questions on our Mortimer Green question bank. All these questions and even more are available on the question bank. 2000 questions updated according to the latest guidelines. And we also do have a regular weekly testing discussion where we discuss all concepts, questions. Usually 30 to 40 questions are covered per session. And this goes on till the exam. We are also coming out with our video lectures. This particular video lecture is a part of the video lecture series to be launched on the Mortimer Green app. For more information, visit www.mortimergreen.org. If you like this video, do subscribe to our YouTube channel. Thank you so much. Hey guys, hope you're doing well. I hope you enjoyed this video. This particular video is a snippet from our MRCS Part A video lectures. What you saw just now was a small part of our larger video series on medical legal aspects of surgery, where we cover concepts on UK health, NHS regulations, child abuse, ethics, consent, workplace scenarios, and much more. All these are important concepts for your MRCS Part A examinations, and some of these concepts will be carried over to even MRCS Part B. Dr. Rohan Khandelwal and I have designed this comprehensive set of video lectures purely to help you clear MRCS Part A exams with ease. And we hope that you utilize this resource. Keep watching this space for more updates, and we hope to launch this video lectures by the end of July or early August. Thank you so much.